Chapter 49, Concepts of Care for Clients with Oral Cavity and Esophageal Problems. The priority concept for this chapter is going to be tissue integrity. The interrelated concepts for this chapter are nutrition, gas exchange, and comfort. A brief overview. Oral cavity disorders affect tissue integrity, nutrition, gas exchange, and comfort. Disorders commonly affect underserved population, tobacco and alcohol users, those who consume an unhealthy diet, or dietary excess. This picture here shows stomatitis. And stomatitis is a very broad term for an inflammation of the oral cavity. Ulcerations are going to be the most common form of stomatitis, and there are two types of ulcerations, primary and secondary. Primary is going to be the most common. Aphthous ulcers are going to be the most common form, and this is also called a canker sore. This could also be herpes simplex 1, cold sores, fever blisters, they're also called, or traumatic ulcerations. Sometimes primary stomatitis can be caused by foods that are high in acid content or hard foods. It can also be caused by vitamin B12 deficiency, so keep that in mind, and we call that pernicious anemia. Tobacco use can cause certain types of ulcerative stomatitis as well. Secondary, that's going to result from an infection of like an opportunistic virus, fungi, bacteria. This is going to be common in your immunocompromised patients, and the most common is going to be candida, and that's going to be your yeast infection. Usually this is going to be present in small amounts like normally, but if you have a disruption like with a client that's immunocompromised or somebody that's taking antibiotics, this type of yeast can take over and can cause a real problem in the mouth. And usually what you're going to see is like a white film, like a plaque type of lesion, and it can be on the tongue, the palate, and sometimes it can even go down into like the cheeks and into the esophagus. This can be removed with scraping. Like if you see, sometimes people will like brush their teeth and brush their tongue and it'll come off, and it could be quite painful. Health promotion is going to focus on proper oral hygiene to minimize the risk. We're going to use a soft toothbrush to minimize pain and trauma, and teach the patient to rinse their mouth out frequently with sodium bicarbonate or salt water, and this can be mixed with hydrogen peroxide as well. They would really need to take their dentures out when they're doing this and make sure that they're brushing their dentures as well. And they also could be taking medications for this, like antimicrobials, depending on what's causing it, antifungals, antivirals. There's topical agents for this. Nystatin is going to be one of the more common ones, and just make sure that you're following the directions on that, because sometimes if they've got this down their esophagus, they need to swallow the medication instead of just swishing it around in their mouth. If it's a nutritional problem, you should be looking at nutritional deficiencies and making sure that if it's vitamin B12 deficiency, that they're getting their vitamins, salmon, leafy greens, eggs, milk, fruit. Make sure that you're staying away from the acidic fruits, because that can cause irritation, and you want to avoid foods that are going to cause serious irritation, especially when you have open lesions. Alcohol can also cause some pain with this, so can hard foods, salty foods, and something that's really spicy. So basically, they're going to want to be on a bland diet. As with anything, we want to do a thorough assessment to determine what the underlying cause is. You should be doing an oral assessment on all of your clients, especially clients that can't speak up for themselves and let them know that there's a problem in their mouth. So make sure you're looking in their oral cavities. Bring your pen lights with you to clinical to do this. Assess for recent infections because of opportunistic properties. So making sure that your clients are that are on antibiotics, that you're doing a nice thorough assessment in there. Assess their diet for nutritional changes because really we want to determine the underlying cause. Make sure that they're not on some type of special diet because some foods can cause stomatitis. And then assess how they perform their mouth care. Ask them what they use. Teach them to practice frequent oral hygiene and to avoid alcohol containing products like mouthwashes. If they use a hard toothbrush, ask them about that. Ask what type of toothbrush they use. Ask them about their denture care and that they should be removing those dentures as soon as possible uh, after they eat and brushing them and cleaning them, especially if they've got an infection going on. Oral trauma, that's really self-explanatory. Drug history, we already kind of went over this a little bit with the antibiotics because that's a common cause of stomatitis. And assess for frequency of outbreaks. Is this happening to them often? Are they having stomatitis on a regular basis? Because we really need to examine any underlying causes because we want to focus on prevention for this. The other thing too we need to talk about with nutrition changes, just to jump back up there for a little bit, because when they have something like this, I don't know about you, but I've taken care of a lot of people with stomatitis, and sometimes they don't even notice it, and other times it's quite painful. So we want to make sure that we're offering soft foods that aren't going to irritate that. So it's not just about like avoiding things like alcohol and spiciness, but maybe it's the texture of the food as well that's going to cause a problem. So assessment, you're going to have a dry, painful mouth. Sometimes it doesn't hurt at all. It just kind of depends on the client. You're going to have white, plaque-like lesions that appear in the oral cavity. Keep in mind that these could be, between the gums and the cheek. You could have them in that buccal area. They could be down the esophagus. So make sure you note the lesion size, shape, color, any drainage if there is any. And then make sure that you're charting all this in the EHR. And then while you're at it, make sure you're palpating the cervical and submandibular nodes because this can sometimes cause some swelling in that area. So our goal here is going to be restore balance and to have a healthy mucosa with no inflammation and no pain. This top picture here, we have leukoplakia. With leukoplakia, you're going to observe changes in the oral mucosa, and that is going to occur over time, causing a thick white film, and that's going to be attached in patches. It's going to resemble the yeast, but it can't be scraped off, so that's going to be the difference there. This can be caused by poor fitting dentures, chronic cheek biting, or broken teeth. Most of these lesions are benign, but those that are found on the lips or the tongue are more prone to progress to cancer. Erythroplakia, that's going to be this bottom one here. And erythroplakia is going to appear as a red velvety mucosal lesion. And this can be confused with inflammatory or immune reactions. It's often considered to be precancerous and they should be biopsied. These are most commonly found on the floor of the mouth, the tongue, and the palate. For squamous cell carcinomas, about 90% of all oral cancers are going to fall in that squamous cell carcinoma category, and they start at the surface of the epithelium. Mucosal euplakia is going to be the earliest sign of this. These may be on the lips, the tongue, the buccal mucosa, the oral pharynx, and they're generally going to be slow growing, and there's going to be a pain associated with later stages. So a lot of times, because pain isn't until the later stages, these are not necessarily going to be caught early. Basal cell carcinoma of the mouth, that mainly occurs on the lips. It's going to be asymptomatic and looks kind of like a little raised scab, and that's going to progress to an ulcer with a raised pearly type border, and generally these do not metastasize. And then Kaposi sarcoma, that is a malignant lesion that occurs in the blood vessels, and it appears as a raised purplish plaque or a nodule. It's usually going to be painless, and it's prominently found on the roof of the mouth, but may also appear elsewhere in the mouth. And Kaposi sarcoma a lot of times is going to be associated with human immunodeficiency virus or HIV. Some major risk factors here are going to be increased age, tobacco use, alcohol use, and sun exposure. So when you're looking at these, you need to think about which one of these are modifiable and which ones are unmodifiable. So some modifiable risk factors, we need to be educating our clients about them, and we want to advise them of the risks associated with that. The occupational hazards that are listed here are going to be modifiable, of course, and we have prolonged exposure to cancer-causing agents like textile workers, metal workers, plumbers, and you have to really think about the longer the amount of time they've been exposed to it, the greater the risk. Periodontal disease, that includes mandibular bone loss, and those individuals are going to be at high risk for developing oral cancer, as well as those that are using alcohol. Presence of HPV-16, that's going to be human papillomavirus. That's going to predispose persons to oral cancer, and this particular classification of cancer usually appears in the tonsillar area or along the base of the tongue. So you'll see a lot of times when you go to the dentist is actually going to have you lift your tongue up so they can look underneath there, and that's what they're looking for. Assessment, we talked about this a little bit before, so make sure that you're doing a thorough assessment on the oral cavity. So get out your pen lights, take a look in there. If your client has any type of denture or appliance that's removable, make sure that they're removing that so that you can look underneath it, not just for these problems, but it could be a problem with poor fit. So you're going to make sure that you're looking for any type of bleeding that's occurring under there. Ask them about their oral hygiene regimen. Ask them about their appetite, their nutritional status. What do they eat? What can they eat? What can't they eat? Thorough inspection, we covered that already. So you're going to make sure that you're getting in there with your pen light. Use a tongue blade. Make sure that you're looking around, look in the cheek, the buccal area, under the tongue, the gums, and make sure that you're palpating the submandibular glands here as well. Non-surgical management may include multimodal therapies. We talked about this when we were in the oncology section, that a lot of times cancer is treated in more than one method. So it could be radiation and chemotherapy. And think about what your priorities are going to be here, because if these tumors are extensive or the patients have copious amounts of secretions, it could potentially interfere with their breathing or their airways. So think about what your priority is going to be here, because we really want to maintain an open airway. So we're going to raise the head of the bed up into a semi-Fowler's or a high Fowler's position, provide suctioning. So we need to make sure we have a suction canister in the room and a Yankar. And we also want to focus on nutritional status and maintaining oral health. Provide oral care at least every 2 hours to clients, and not just with oral cavity issues. A lot of clients need that type of care. Otherwise, they could end up having a problem with the oral cavity. So make sure that you're cleaning that out, and teach patients to do that themselves and family if they're able, and avoid commercial mouthwashes again, because they're usually high in alcohol content. We can rinse the mouth. We can do that with warm sodium bicarbonate water. Radiation, these can be internal or external. So again, we talked about this in oncology section, could be beams or seeds. Just keep in mind that radiation, especially in that area, it could potentially cause stomatitis, especially with clients that have like cavities, because a lot of times the radiation is going to magnify through those fillers that they've used to fill the cavity. So we're going to encourage frequent oral care. So skincare is going to be important. And then keep in mind too that depending on where they're actually receiving the radiation therapy, that itself can cause burns. Surgical management, this is going to depend on the size of the tumor. Sometimes if the tumor is relatively small, it can be removed in the office. If it's larger, they may need to be admitted or to have an outpatient surgery under sedation. Pre-op care includes preparing the client and the family for post-operative care, because we start to educate the patient on a day of admission. So a lot of times I'm going to be telling the patient what to expect depending on where this tumor is located. You need to think about, is it going to be located where it's visible? Is it going to be located inside the mouth? So both of those two things are going to affect your patient differently. If it's internally, they could have problems swallowing. If it's external, like on the mouth, the lips, they could have some like cosmetic issues that are going to come up. So you need to prepare your client for that. So if it's a smaller tumor, sometimes they're going to be on a liquid diet for a day. It just kind of depends on how extensive it is. If it is larger, they may end up having to require some temporary, like alternative method for food, like TPN or a G-tube placement, depending on the client's effect of the surgery. Incisional care for larger tumors. So some of these patients might end up requiring a trach. If that's the case, they're really going to end up having a G-tube for nutrition. So they could have temporary loss of speech with this if they end up having a trach. So you need to make sure that you're warning them of that so that they don't wake up surprised, not knowing that they're not going to be able to speak. If I know that this is happening with my client, I will figure out a way to communicate with them before they lose their speech. It's a little bit easier to figure things out before that happens so that you can ask them what their preferences are. They're going to require IV hydration, nutrition we talked about, and then they could possibly have surgical drains. They probably will have surgical drains, but not 100% of the time. So we need to talk about care with that. Back on the speech for just a minute. You can always get a speech consult as well. You're going to end up needing one of those anyway, because the patient's going to need to work with speech for swallowing and communication in the future. The other thing too I want to mention, I've seen this happen a lot. We kind of tend to ignore as healthcare professionals the psychosocial aspect of it. There's going to be a lot of issues, especially if they have a change of appearance or they end up with a trach. You need to make sure that you're taking care of that aspect too. So you may need to get psychiatry involved with this. In fact, I would just assume you're going to need to, and ask in advance. Just make sure you ask. Sialadenitis, this is an inflammation of the salivary glands, generally related to decreased salivary production, and that is going to be due to an infection. A lot of times radiation can cause this, staph organisms, E. coli, things like that. Sialadenitis from post-irradiation exposure, is going to cause xerostomia, which is going to be your dry mouth, and this can be temporary or permanent. So we really need to offer artificial saliva to help these patients that are experiencing this, and increasing their oral intake if they're able to do so. Salivary gland tumors, these are relatively rare. They're going to be slow growing. Sometimes with these, they involve facial nerve issues. Sometimes the tumor can be wrapped around the facial nerve, and this can lead to paralysis of the affected side. And sometimes one of the first signs of this is going to be like if all of a sudden your client is not able to wrinkle their brow or raise their eyebrows or puff out their cheeks. So that's why doing a thorough neurological assessment is going to be important with this. And they could have the inability to squeeze and hold their eyes shut too. So think about all of the ramifications that would go along with that patient not being able to close their eyes. This picture here is showing some GERD. So we've got reflux of gastric acid that is coming up here into the esophagus through the lower esophageal sphincter. And this is going to result in reflux or GERD, gastroesophageal reflux disease. So GERD is going to be the most common GI disorder in the United States. Those most effective are going to be your middle-aged, older adults, but this can really happen at any age. And like I mentioned on the previous slide in the picture, we've got a backwards flow, in this case of stomach acid contents backwashing into the esophagus, and this is causing irritation and inflammation. Most commonly, the cause of GERD is going to be the excessive relaxation of the LES, and those are most at risk are going to be your overweight and obese persons. The reason for this is going to be because there's an increase in intra-abdominal pressure because of the larger body, especially around the central part of the body. Other causes are going to be laying flat at night when peristalsis is slowed down and gravity is not allowing for downward flow of stomach contents. So sometimes you'll see these clients are not able to lay flat. Hiatal hernias, they also increase the risk of developing GERD. And again, that's because of an increased in intra-abdominal pressure. H. pylori or Helicobacter pylori can contribute to reflux as it creates chronic gastritis, which in turn slows down gastric emptying. And then for Barrett's, instead of the body producing new squamous cell epithelium during the healing process, it would start to produce Barrett's epithelium. And this is more resistant to stomach acids and aids in healing. And it's also considered pre-malignant, so it's going to be associated with an increased risk for cancer. Another concern of the healing process is esophageal strictures because of scarring that accompanies the healing process. This can lead to an increased difficulty with swallowing, so I want you to think about what your major concerns are going to be when swallowing is impaired, because we need to worry about aspiration with our clients, which can lead to pneumonia. So for assessment, we're going to take a very thorough history. We're going to ask our clients if they have a history of heartburn or chest pain, asthma, hoarseness, pneumonia, dyspepsia. So dyspepsia is going to be one of the most associated symptoms with this, or a feeling of abdominal discomfort, bloating, nausea. Sometimes they may have some regurgitation from the backwards flow of stomach contents into the throat. Eructation is going to be belching, flatulence, of course, is passing gas, dysphagia, difficulty swallowing. So these are all terms that you really should be familiar with. So if there's terms in your textbook as far as medical terminology that you're not familiar with, make sure that you're writing those down and probably making a flashcard to help you out. And there they all are. Diagnostics, we're going to do an upper GI series, a barium swallow, and that's when the patient actually swallows the barium. And this is going to be helpful in detecting strictures or disorders of the esophagus. EGD, that's when you're actually using a camera scope, so the patients are put under sedation, and this is one of those informed consent things because we're sedating the patient. So they're going to take a flexible scope, and that's going to be inserted through the mouth and down into the esophagus, into the stomach. It goes all the way to the pyloric sphincter, and they're doing that to identify and visualize GI structures of the stomach and the esophagus, of course. So again, invasive requires a prep. They have to be NPO for 6 to 8 hours prior. They should be signing a consent for this. They need to have somebody driving them. They can't drive afterwards or make serious decisions afterwards. They should be avoiding anticoags and NSAIDs for several days beforehand. So you need to get the doctor on board for this, because we can't just hold medications without consent, so we need to make sure that the doctor is aware. Moderate sedation is administered, so sometimes the patients will, sometimes they remember things, but mostly they really don't. Follow-up care includes maintaining NPO until the gag reflex returns. That's going to be your priority with that, so they need to make sure gag reflex is returning. Frequent vitals, of course, post-op vitals. We're going to monitor for bleeding. And again, the client will need someone to drive them home. pH monitoring. This is considered to be one of the most accurate ways to diagnose GERD, and it reads the pH of the stomach. A small catheter is placed into the distal esophagus. I've seen them do this where the patient gets this inserted through their nose, down into their stomach, and it gets taped to the side of the face. The patient keeps a food diary for the next 24 to 48 hours, and they can go about business as usual. They can go to their job, they can do whatever their normal plans were. They just have this little thing sticking out of their nose and taped to their face. Esophageal manometry. This is going to be used to measure that sphincter, the LES, the pressure in there. So it's a water-filled catheter, and it's inserted and slowly withdrawn, and measures the LES pressure, and peristalsis is also going to be recorded. If it's inconclusive, a gastric emptying study may be ordered, and the patient is going to eat food for that that's marked with radioactive dye. And the client's then monitored under imaging for the next several hours to assess the rate of gastric emptying. With this, a lot of times your patients may be asymptomatic at first with just occasional heartburn, and a lot of times they're just going to think, well, maybe I just ate something that was a little too spicy for me, and I'm going to just take a Tums and then continue on with their habits. As a nurse, you need to know that you're teaching the client about taking over-the-counter medications. And we talked about this with acid-base balance. Sometimes your clients will take too many of those Tums, and they create another problem. So the other thing too is we want to talk about prevention. So we don't want it to lead to progression to something a little bit more serious. We want to talk about healthy eating habits, give some examples too, like ask them, what are you eating? Because if you just tell a client that, eat healthy, their healthy may be different than you're healthy. A lot of different examples there. I used to think that rice was a good food for me, and now I found out found out years ago it's got a lot of carbs in it. So that's just one example, and your clients have hundreds of more examples on what they think might be healthy. Sit upright for 1 hour after eating, sleep with the head of the bed elevated. Weight loss is going to help with that, and avoiding alcohol and caffeine. So those are going to be some triggers for that. So think about your nursing focus for this client. We want to improve comfort and relief of symptoms. So think about how you would do that. We prefer things to be relieved non-surgically, so it's less invasive and less healing time for your client. We already talked about some lifestyle changes, but I want you to think about what medications might be out there. Think about your PPIs, your proton pump inhibitors, your histamine blockers, such as ranitidine, proton pump inhibitors, omeprazole. So we really want to be educating the patients on how to take those, when they should be taking them, if they should be taken on an empty stomach. It's also wise to be talking to the doctor about any medications that be contributing to GERD. So some examples of that: NSAIDs, nonsteroidal anti-inflammatories, they could be contributing to GERD, as could calcium channel blockers, anticholinergics like allergy medications. A lot of people take those over the counter, ditropan, oxybutynin, antidepressants. There's a lot of different medications that are going to contribute to GERD. And then there's some surgical treatments that we can do to help manage these patients. So endoscopic therapies like the Stretta procedure, and that's a radio frequency that's provided through needles into the gastroesophageal junction. And this decreases stimulation of the vagus nerve and decreases discomfort. And I believe that there's a chart in your book that talks about that as well. And then surgical management are going to be only for those who have failed medical treatment or who have developed complications from prolonged GERD. Hiatal hernia. So this is what your stomach should look like. There's your diaphragm, and there's your stomach below the diaphragm, and your esophagus above the diaphragm. And we can see here that in this picture, this is no longer normal. So this portion is a herniated portion of the stomach. So it has moved above the diaphragm. This one, a rolling one or a sliding one, they move. So it might sometimes look like this and sometimes look like that. We want it to be like this. Hiatal hernias are also called diaphragmatic hernias, and that is the protrusion of the stomach. We already talked about that right here, so this is normal. And right here we have the stomach protruding through the diaphragm, and again in this picture. And excuse me. So we have protrusion through the esophageal hiatus of the diaphragm into the chest due to weakness of the diaphragmatic muscle. A lot of times there's going to be increase in abdominal pressure. Sometimes these clients will end up having pressure in the chest as well because this should not be there. So it's causing pressure. And they may be symptomatic, or they may have symptoms similar to GERD, which kind of makes sense because if the stomach is above the diaphragm, there's really nothing stopping all of those fluids going up there. Okay, so assessing again, inquire if your patient has a history of heartburn. Esophageal reflux is pretty common in these patients with a history of a hiatal hernia. They also could be having chest pain. Makes sense, there's all that pressure up there. Asthma, hoarseness, pneumonia, and dyspepsia. Feeling of fullness and nausea. Regurgitation again, dysphagia, loss of appetite could be possible. So you're going to assess their appetite. What have they been eating? Are they getting the required nutrients? And when is that discomfort happening? Is it getting better when they worse, or does it does it get better when they eat, or does it make it worse? So those are important things to note. The most common diagnostic test for a hiatal hernia is going to be a barium swallow under fluoroscopy. And they can easily visualize the stomach when they do this for the location of any hernias and any abnormalities. So how do we care for these clients? We can use similar non-surgical interventions like we do with GERD, healthy living, weight loss to help relieve abdominal pressure, not laying down after meals, elevating the head of the bed during sleep, and there's some medications they can be taking too. Surgical management may be necessary when the risk of complications are high, because we don't want these patients to end up with a volvus or a strangulation, or also when the chronic reflux becomes severe. The most common type of hiatal hernia repair is going to be the Nissen fundoplication, and that's when the doctor is going to wrap a portion of the stomach fundus around the distal esophagus, and that's going to be to anchor it in place and reinforce the LES. This can be done either laparoscopically or transthoracically. Pre-op instructions for non-urgent surgery are going to revolve around lifestyle changes and weight loss. They're going to ask the client to stop tobacco use, and the post-op expectations are going to be included in there as well. Post-op care includes management of any chest tubes or NG tubes, use of incentive spirometer. Pulmonary hygiene is going to be important with this, early ambulation. We want to make sure that we're preventing post-op atelectasis and pneumonia. Oral intake can be gradually reintroduced after peristalsis has returned. So a lot of times they will be started off on clear liquids when their diet is resumed, and they will progress as tolerated. And we're also going to monitor for bleeding and signs and symptoms of infection. Esophageal tumors, just like with any other type of tumor, they can be benign or be malignant. Some of them are benign, but most are going to be malignant and arise from the epithelium. And there are going to be two types of esophageal tumors. There's going to be the squamous cell, and that's usually located in the upper 2/3 of the esophagus. And the adenoid carcinomas, they're going to be most commonly found in the distal portion, the distal third, and they are the most common type. Esophageal tumors grow relatively rapidly, and more than half of them metastasize, and that is because of the rich supply of lymph in the esophageal mucosa. Major risk factors of this are going to be smoking and obesity. And as we discussed earlier, obesity leads to increased intra-abdominal pressure, resulting in the weakening of the LES, and then reflux of gastric acid. So GERD, gastroesophageal reflux disease, is going to cause an increased risk of cancer in this area. So GERD, again, is going to cause damage to the epithelium, and then it's going to be replaced by Barrett's epithelium, which, if you remembered, is considered precancerous. So risk factors, gender specific here because males have a higher incidence and mortality rates with this type of cancer. Smoking and alcohol use are going to increase this. We also want to ask about dietary habits, consumption of smoked and pickled foods, things like lunch meat, pickles, of course. Increased acidity. Smoked meats have carcinogens in them, so things like sausages are going to be an increased risk. And everything, of course, moderation. If their diet's like 100% smoked meats, then they're probably going to have a problem. But if it's every once in a while, that's a completely different story. Dysphagia, that's going to be one of the most common signs of esophageal cancer, so they're having trouble swallowing. Strictures are going to occur more frequently, and they're going to complain of having food stuck in their throat. They could have some painful swallowing, and that often results of invasion of the surrounding mediastinal strictures. Weight loss is going to occur, and we would say probably about 20 pounds or more over several months. And halitosis, bad breath, and then sometimes too they will have hoarseness, and chronic hiccups can occur with more advanced diseases. Psychosocial assessment, again, high anxiety, and it's not just because of the terminal nature of cancer. I mean, cancer treatment has come a long way, but still that word kind of induces fear in people. But also, I mean, that's your airway. Like that, I know it's your esophagus, but it's still in the same area as your airway. And a lot of people can have that fear that they're not breathing properly. It can cause a lot of anxiety, a lot of issues with eating afterwards. That feeling of choking, like they're not getting like they're getting their food down. And then there's a huge social impact with eating in front of people, because really these people should be these clients should be eating in front of their family, because if they do start choking, their family can help them. But sometimes there's an embarrassment factor. They may not be able to swallow adequately. They may choke, and they get embarrassed. So they need a lot of support. So coping mechanisms, support systems, and of course resources for them. Diagnostic assessments, we have esophageal ultrasound with needle aspiration biopsy. They can this can be differentiated. This can differentiate solid from liquid masses. Esophagastroduodenoscopy, that's your EGD. That can visualize and take biopsies as well. They can also perform dilatation. So say your client is having a lot of trouble swallowing and it turns out that it's a stricture, they can do a dilatation under EGD. And then your PET scan, that's positron emission tomography. And this is going to be to help better detect malignancy than a CT or an MRI. So what this involves is your client should be avoiding carbs for a couple days beforehand, alcohol, things like that. So they deprive the client of those things, and then they have to be NPO after a certain time. And in the morning, when they come in, they get their IV put in, they will inject a radioactive isotope sugar, and that sugar is metabolized by cancer cells faster than it is by healthy cells, and then they will scan them and they will detect that radioactive sugar and determine which areas are more likely to be cancer and which ones are not. So afterwards, so the major concern for clients with esophageal cancer is going to be weight loss related to the dysphagia. Nutrition and swallowing therapy are going to be essential for these to prevent malnourishment. So these clients really need to be seeing a speech therapist if they're having trouble with their swallowing, and then a dietitian as well to help determine what they need for caloric intake and how to best achieve that. A lot of times these patients will need something that's mechanically altered and something that is soft, so they might need thickened liquids to make it easier to swallow, and they might need some supplements. There's a lot of really great nutritional supplements like Ensure. There's some with higher protein levels, some that are for diabetics. So we need to make sure we get the dietitian on board, because they will actually look at the patient's labs as well and determine what they need to maintain their weight. The whole goal of that is to prevent them from needing a feeding tube, because there's another theory that if you don't lose it, you lose it. So we want to maintain the swallowing as long as we possibly can, but we also want to keep them safe and away from aspiration. The other thing with speech too is they can help to train the patient how to take their medications properly too, and not just with swallowing, but with food, but with their medications, because sometimes you see those clients that will put their pills in their mouth and they'll throw their heads back to swallow them, and we don't want them to do that. We want them to tuck their chin. Okay, chemo and radiation, they can be used as primary therapy or adjunct therapy, or primary if the patient's not a candidate for surgery, or purely as a palliative measure to control symptoms. Although things things like chemo and radiation, they're going to only be moderately effective with most esophageal cancers. What they're going more towards is targeted therapies, and these therapies interfere with cancer cell growth with a lesser impact on healthy cells. And these are usually used in conjunction with chemo and radiation. Surgical interventions, they might do an esophagectomy. That's going to be removal of all or part of the esophagus. And sometimes they're going to remove part of the stomach as well. So that'd be an esophagastrectomy. That's removal of part of the distal esophagus and the proximal stomach. Pre-op, they have to stop smoking 2 to 4 weeks prior, and 5 to 6 weeks of pre-operative nutritional supplementation. So we're anticipating there's going to be some weight loss there, so we're trying to beef them up a little bit. They may have oral, PEG, or TPN, and a nurse will focus on teaching and psychological support as well post-operatively. And make sure, again, you're teaching these clients about all of these issues during the pre-op phase. Post-op, client will receive intensive care post-op, including because they're worried about respiratory compromise. So we're going to keep the client in a semi or high Fowler's position. We're going to support them. A lot of times they're going to need increased ventilation because we don't want them to have issues there. We're going to try to reduce reflux. The client will likely be on supplemental oxygen and or ventilation immediately after surgery. They could end up with a tracheostomy again. The other thing too is these patients could have a risk of leakage at the anastomosis site. And anastomosis is where they've joined the two sections of the GI tract. So that's pretty life-threatening. It can result in sepsis, but we don't often see the sepsis until about 2 days to 10 days after surgery. They will have an NG tube in place to decompress the stomach, and it's not to be used for irrigation or for feeding, because you have to keep in mind we're not going to be using that stomach for a while. So if they do have a PEG, it's going to be like at the J site, the jejunum site. So that's going to be strictly for nutrition, but not in the immediate post-op phase, because we were worried about tearing. So before oral feedings can resume, they're going to do imaging studies to make sure that everything is intact and that that patient is not leaking at the anastomosis site. Lots of post-op care with this one. So our goal with all of this is for the client to be able to consume adequate nutrition and maintain a stable weight. Okay, last slide on this one. Esophageal diverticuli. So these are going to be, if you've heard of diverticulitis, yes, it can happen in the upper GI tract as well. These are sacs that form due to herniation of the esophagus, the esophageal mucosa and the submucosa into the surrounding tissue. The first signs of this are going to be difficulty swallowing, reflux, a nocturnal cough, halitosis, and these can all be diagnosed by an EGD, and they can be surgically removed if necessary. Trauma, this can be from blunt injuries, chemical burns, stress and vomiting. Chemical burns, I've seen some that where the client either accidentally or intentionally consumed something that burned them, and those are going to cause some trauma. They can also be caused by stress from vomiting. So they're going to be evaluated and treated in the ED, assessed for breathing and airway patency, chest pain, vomiting, and blood. And then think about nutrition with these as well. So patient may need long-term nutrition, especially if the trauma is significant, because we want to make sure that they're not eating, because we don't want to make the trauma worse. Okay, that is the last slide again. We have review questions again, so I will make sure that these do get posted so that you can review them. And that is all for Chapter 49, Concepts of Care for Clients with Oral Cavity and Esophageal Problems.